Hi, my name is Dr. Lawrence Wallace, and this is the live webinar on May 22nd, 2014 for the Laurel One-Step Denture. We're going to go through the procedures and the processes. We will show you everything involved in this unique new process that is really gaining a lot of traction throughout the dental community. We have lectured in many areas, and we've lectured in many areas, and we're going to go through the introduction. We'll go through a lot of the processes. Then we're going to have some questions, and then we're going to have a full video that's going to show you exactly what the process is, so you can all incorporate this into your practices. It's a very easily learned technique. It's very profitable for you as the dentist. It provides a great service for your patients, and I think you will like it. This is me. I met many of you in Anaheim at the CDA Presents last weekend, and many others of you were familiar with me through an article we had published in Dentaltown magazine just this last week. And I am a graduate of the U of I College of Dentistry, oral surgeon, board certified. I practiced for 25 years. I developed the Laurel One-Step Denture in 2005, and a couple of reasons that I did that. One of the reasons I did that was in dental school I couldn't get a denture to fit no matter what I did. And so that made me go in to become an oral surgeon. And the other was I took out so many teeth during my practice that I felt that after my retirement, which was a forced retirement because of back problems, that I needed to find a way to give back and kind of help replace all those teeth that I had removed. Here's some of the, quickly, some of the demographics. There's probably more than 37 million edentulous right now, with 2 or 3 million more each year. Not everybody wears dentures. And though you can read articles that say there's going to be more and more people keeping their teeth, and there are, as the population ages, there also, because of the increase in the population, there will be more people needing dentures. And since the economy has not really recovered to the point where it was, where everybody was doing implants and veneers and fixed bridge work on all their cases, dentures will still be needed. The article that's quoted on the bottom, will there be a need for dentures in 2020? The answer basically was yes. There still will. The number who are needing dentures will continue to increase, and this was published in 2002 before the economic downturn. The market sectors that these dentures are most used in are private practice, obviously, is the first one. But they're also very useful in skilled nursing homes, in assisted living residencies, and mobile dental clinics. They're also a great opportunity for those who are working not in homes and don't have insurance benefits. Approximately half of the edentulous people in the U.S. are under the age of 65. The demographic breakdown is about half and half. Of course, there's so many more people who are under 65 that the percentage is lower, but the numbers are still there. And they're in all parts of the country, and they all need care. So what are the clinical situations that we'll use the Laurel denture in? The first and most obvious is complete dentures, people who are currently edentulous. They are used to restore them with the denture prostheses so that they can eat, function, and have a quality of life. Also, a major use is for immediate dentures. And we are using our dentures for people who are having their teeth removed and having immediate dentures placed. And contra to the standard technique of taking an impression, having the laboratory remove the teeth from the model and create the denture and then take the teeth out, our technique goes just the opposite, and we suggest that you take the teeth out first, then take the impression. And we're going to go through all these steps and show you cases of immediate dentures. Go through this, take the teeth out, suture up the gingival tissue, have it just the way you want it, then take the alginate impression and then form the denture to the ridge the same way would be for a fully edentulous. Other uses, major use coming right now is implant overdentures. We are using the Laurel denture in combination with immediate load narrow diameter implants. Many doctors are using this right now, and their time frame is about an hour and a half to place the implants and complete the dentures. It's a technique that is extremely popular with patients because of convenience. I will say, and we're going to go over this again, but originally part of the reason that this process was so accepted was because of the lower cost for the dentures, but the convenience of being able to do it in a single visit has almost eclipsed that. So for all dentures, all denture fabrication, these are the principles that must be met. The dentures have to fit well and comfortably, they have to look good, and they have to be able to be used well. But there is another principle that must be met, and that is patient expectations. You'll hear all kinds of reasons why patients don't like their dentures, why they are having problems. It isn't all about the acrylic. It's about meeting patients' expectations. Because what we don't want is we don't want this. We don't want the jar full of dentures. This is a typical patient who had come into one of our offices and wanted a set of dentures. In talking to her for a few minutes, we were determining what her expectations were for getting dentures. We don't judge anybody on why they have no teeth, no matter what age they are, but we wanted to know what this patient expected. Well, this is what she wanted to look like when she walked out. And as soon as we realized that these were her expectations, we knew we weren't going to meet them. So we had to realign her expectations, and we did. And she finished the process in about an hour. She walked out with her dentures, and she was extremely happy because we had reset her expectations to a reasonable and realistic level. So do our dentures in an hour meet standard of care? Standard of care is defined as I said here, and the standard guides our practice, and it is used to evaluate performance. So if we provide a service that meets the performance standard that we have and our profession has accepted, then we have met the standard of care. I'm just going to show this real quickly. These are the only statistics I'm really going to show. This study in 1996 in the Journal of Prosthodontics was patient satisfaction with their dentures. And you can see that these numbers are all in the mid-60s to the higher 70s of the adjustment and liking their dentures. Well, this was a survey that was done with similar questions for the Laurel dentures done after a clinic that we did. And the only trouble reported was with apples and corn on the cob, which were typical and are typical of many of the issues all of the time. So you can see that these numbers were really good, and the patients were really happy. They were able to eat. They were very pleased with the appearance and overall satisfaction. And we feel that this kind of results does allow us to meet the standard of care. There are several principles of the dentures that we're going to talk about. I eliminated the research that came up with these, but there is actual prosthodontic research going back through to the 30s, to the 50s, 60s, and 70s that define the principles for dentures. This is all from the classic literature. We meet those, and these are features that we have, and we'll go through these later on and you'll see these, but we have the teeth over the ridge. We use 3 posterior teeth. We use 1 premolar and 2 molars, and I will go over the reason why we do that. It doesn't really impact the patient's ability to eat, but it does help to keep lower dentures in place, and we'll demonstrate that in a few minutes. The lingual flange is concave for better retention and to help the tongue be in a normal position, because the research shows that if the tongue is in a normal position, the lower denture will be more stable. The research also shows that maxillary occlusal plane is set first for appearance, and we do that. We use monoplane teeth for maximum comfort and least tissue damage. The cusp teeth are much more degrading to the underlying bone and tissue because of the forces, lateral forces that are placed on it. The monoplane teeth have about 85% to 90% of the chewing efficiency and are much kinder to the patient and much more comfortable. Adapted templates for proper thickness of reline material. Through our process, we're able to do that, and we will demonstrate that. But these are all taken from the classic literature. Here's some of the results that we have achieved through the clinics that we have done. All of these clinics are either 1 or 1.5 days, and they are showing that we, with usually about 4 doctors, are able to do anywhere from 70 to 100 dentures, depending on the situation. Some patients have 1 unit done, some have upper and lower done. These are some of the patients. And at this point, I want to describe that we use a single mold of tooth. There's only one shape. It seems to be a very chameleon-like shape, and no matter what the facial structure, the patients seem to be happy with it. We have 2 shades available in our products. They're a B1, which is a very light shade, and a B65, which is a universal shade. The larger templates, as you'll see, will have larger teeth so that the canines will be under the pupils of the eye for a natural look. The patient in the lower left was able to be had, and we'll show that again later as well, able to have the gingiva tinted darker so it is a more natural appearance for patients with darker skin. So what is the main difference between the Laurel denture and a conventional denture? Well, you can see that we're able to do it in 1 visit in about an hour. There is no lab cost. The average price of dentures in the United States for 2014 is $3,400 per set of upper and lower. That's national average. There are places where it's lower, there are places where it's higher. We suggest a retail to our patients of these dentures of $1,200 for the set of upper and lower. And we're going to go through the economics and the numbers of it so that you'll understand how this will be profitable for you. This is what the system looks like. We have 5 sizes of preformed templates. The templates are made out of a thermoplastic material, and as you'll see, that material does become malleable when it's heated in boiling water. There are 5 sizes. These sizes were determined by measuring to specific measurements that we created, such as intertuberosity distance, incisal edge to posterior distance, just an entire array of measurements. We measured over 1,000 edentulous models that came into a dental laboratory to determine the sizes. We then took the sizes and took the numbers and put them into a spreadsheet program, and we're able to determine the 5 sizes by grouping them. We can accommodate approximately 99% of the edentulous population. There are going to be people who have situations that just are not amenable to what we're doing, and those people will need custom traditional dentures made for them. But for just about everybody, with the thermoplastic material and the ability to move the teeth and the ability to tint the gingiva and the other customization that we can do, we can now accommodate just about everybody. Our templates are all made in the U.S. from all U.S. materials. We use Meyerson-Kenson teeth. It's a very good grade of acrylic tooth. We don't use porcelain teeth. Our templates are manufactured in Los Angeles, and we use reline materials that are also manufactured here in the United States in Illinois. I'm going to quickly go through the process and describe it. You're going to see the process 2 or 3 times on slides, and then you're going to see the entire process in video. So if you miss something right now, don't be concerned. I will be repeating it, and we'll be able to show everything. The first step in the process, of course, is to take an alginate impression, pour up a quick-set stone. In the early dentures that we did, we were able actually to put the denture templates in the boiling water, make them malleable, and manipulate them right inside the mouth. But we found that it was quicker and faster and easier to do it on a stone model. So we take a stone model, pour it up in quickset stone like snapstone, so in about 5 minutes it is fully set. We then want to have the template formed to the model, and we'll show you how to do that. The first step is to trim the flanges so you have about 2 to 3 millimeters of space from the height of the flange to the height of the ridge. You cut out for the frenum, and you cut out for any muscle attachments that you might see. You can then place the closest fitting template onto the model. And I'll go back for a second here. The closest fitting template will be one that if you place upside down, and I'll show these slides later on so you will see that, the teeth are over the ridge. The template on the left photograph you can see has been partly adapted to the model. You can see that the left, on the left side of the photograph, the right tuberosity has not been fully adapted. That is going to go into the boiling water, and it's going to be become malleable so that the palate is firmly adapted to it. You can see in this photo that we are using 1 premolar and 2 molars. We'll show a lower photo, and that will be a better understanding. In the right photo, you can see that we do want about 2 to 3 millimeters of space from the height of the flange to the height of the fold, and the cutout for any frenum or any frenums or muscle attachments. The template is malleable. We will show that very shortly. The first step, of course, is to measure vertical, and that is done in the standard technique of having the patient stand prior to sitting down and put a dot on the nose and a dot on the chin and make that measurement with the patient's facial structure relaxed. If the patient has no teeth, you know that vertical is a guess, but it's a pretty good guess, and it's an educated guess, and we are able to come pretty close. You can see if their lips are together too much, or if they're stretched and have lip incompetency, but you can pretty much figure that we're going to be right in the middle if the patient is standing there relaxed. Our final goal is to have the measurement that we have made less 2 millimeters for the freeway space, and that is important so that the patient will be able to speak well. We're going to place the template, show you placing the template and how we determine all of those things. So we now have the template that we've tried in the mouth. The video will show you how it goes in the boiling water and becomes malleable and is formed to the model. But it hardens in about 20 seconds, and once that happens, it handles just like standard denture acrylic, and it cools extremely rapidly. So the template is tried in the mouth after the flanges are fit, and the flanges need to be checked once they're in the mouth. We do recommend that you use an edentulous impression tray for the alginate impression, though a standard alginate tray can be used. The issue with that is that the higher flanges on the standard alginate tray tend to displace the tissue a little bit, and therefore the flanges on the denture might be a little long and need to be adjusted again when they get to the mouth. But you try the upper template in. Everything is based off the upper template. The speech, the occlusion, and the appearance are all based on the upper template. So it's tried in the mouth. There are 4 planes that we use to determine the right position of the denture. The first is the allotragal line that you see in the left photo, which is determined with the template in the mouth with the Fox plate, which comes with our kit, by the way. The second dimension is the Frankfurt horizontal, I like to use the interpupillary plane as a better determinant of the horizontal measurement, because it's a little more natural if you match the patient's pupil line with the denture occlusal plane. And not everybody's pupils are even. One eye might be a little higher than another, and so it is a little more natural. It's important to know that tooth show is visual and lip support is visual. So the up-down position of the incisors of how much tooth is showing is visual. The lip support, or the anterior-posterior position of the template, is also visual. And you'll see the lip support instantly, and you'll see the tooth show asking the patient to smile while you're holding the template in, and you'll see what will be a natural look for the patient. The patient can actually look in a mirror and say, yeah, I like that. And if you want to position that template prior to the reline, you can put some stops in with the reline material and just try it back in the mouth. Make sure you have it exactly where you want, and then you can go and do the chairside reline. All of this we're going to show through the cases. So after you have positioned the template, you know exactly where you want it. You will put an adhesive sealer, which comes with the kit, into the upper template, because we do the upper template first. In summary, the reline material is placed into the upper template and it's border molded at that point. And at that point, what you're doing is a standard chairside reline. You'll take excess material with a cotton tip applicator and move it off the teeth so it'll become easier to finish. You'll check for voids, and if there are any voids in the reline, you can add more material. It is very coherent with itself and will not cause a problem at all. The post-dam is going to be added at a later time, and we'll show that process being done and how the benefit of that. So the left photo, upper left photo, shows the initial template before it's been adapted. The right photo shows the reline material being placed into the template. It will be extended, so it goes back to the posterior border and fills the template. Since we have adapted the template very closely to the arch, it is not necessary to overfill the template, so that way you won't have too much coming out over the sides, over the rolls. But then it's placed in the mouth, border molding is done, muscle trimming is done, and it's taken out of the mouth. And again, you'll see all these procedures. You'll see all these procedures as we go along. The lower photo is a finished template that is a shade B1 template, B1 tooth. And again, you can see there's one premolar and two molars, and we'll get to that demonstrating why more so when we get to the lowers, because that's where the issue is with the lowers. All of this will be seen again. The upper photo shows what the reline material ought to look like when it's complete. Now, this material is a reddish color. This is not the material we are currently using, but this makes for a real good demonstration. The material we're currently using, which is Lang Flexacryl, the fibered pink version, is a virtual identical match for the template. So it is almost impossible to see the demarcation point between the reline material and the template. But this material demonstrates how it ought to look when you're finished. If you have done the reline and you need to add a little more on to the reline, you can do that very easily. It is easy to put another wash in. Now, the lower photo shows a little bit of crossbite on the right side. That's really okay. Because these are monoplane teeth, there will be no interferences with the occlusion, and we want to get the teeth over the ridge. And typically, since lower ridges resorb anteriorly and laterally, the lower teeth might be in an edge-to-edge or slight crossbite occlusion. If this occurs, it is not a problem for two reasons. One, because of the monoplane occlusion, as I discussed, and secondly, because the upper teeth are now slightly lingualized, and that helps to retain the lower denture. So if you need to have them not in an ideal overlap situation, you want the uppers a little bit lingual. So after you've relined them, and again, we're going to go through the entire procedure twice more and see it in the videos so that you will understand all the steps of the process. We'll recheck for voids and fill it in if necessary. We will place the post-dam, and I wrote here if necessary because many patients won't need the post-dam. The post-dam goes back to early days of processing of acrylic, and there was shrinkage from the cast, and therefore the seal was not as good. We get a really good seal, and some patients actually do not need the post-dam. We generally recommend putting the post-dam in, and we'll use a cement spatula, and you'll see that being done. Just paint it in. A doctor in one of our seminars said, how do you know how big to make the post dam? And my response, not to be coy or not to be flighty about it, I said, well, how big do you tell your lab to make the post dam? And the answer is, well, I don't. Well, that's really the answer. Is it's if we have it about 1 millimeter high and 1 millimeter wide, we're going to check it with pressure indicating paste, and so that will show us if it is too big and too high and it can be trimmed down. We definitely recommend pressure indicating paste to check the intaglio surface of the denture to make sure there are no high spots or rough spots, and articulating paper to finalize the occlusion. Let's move on to the next step. This is a case study of a complete denture. I'm going to go through this quickly. The template was adapted. You can see this patient has a higher palate, and so it was put in the boiling water, and the template was modified. First thing, placed on the model, make sure the midline is right, and then adapt the palate. Once you have the palate adapted, you can go to do the flanges, and because the acrylic templates have no memory, you can take them to the water multiple times and not lose the adaptation that you have. So in this case, we had to do it once or twice. You can see in the right photo that the posterior border of the template is not exactly even. That's okay. After the reline is done, it will be smoothed off and it will be right at the vibrating line, and it won't be a problem. The vibrating line you can check with either a Thompson stick, which is the gentian violet stick, to mark where the vibrating line is, or you could use a Sharpie or any other kind of marking material, or you could mark it mark it with on the model and then trim the template back. They are translucent, so you can see through it. The lower is prepared the same way. You can see in the right side photo there's a black mark at the top right of the photo. That represents the crest of the ridge, and you can see that these teeth are over the crest of the ridge. I'm going to demonstrate here, or here's where I'll talk about why we only have 3 posterior teeth. We took out a premolar and have 2 molars. If we had had another premolar in this case, the teeth would be back another 6 or 7 millimeters. The buccinator muscle courses right across that area, and if the teeth are set, lower teeth are set too far posteriorly, the buccinator muscle will hit the second molar and it will tend to unseat the denture. So we brought that forward a tiny bit. We've removed some of the flange area on the labial, and so that everything we're doing is to keep the dentures in place. Again, for a full denture, this is the process of placing the reline material. In the lower photo, you can actually see that the post dam is in place in this, because that is a completed template. It is virtually indetectable from a conventional denture. The material we're using now has a very good interface between the template and the reline material. Here's the lower. Again, this lower was done with the other materials, so you can see the extent of the reline that we're doing. Now, in some areas, there'll be very little border molding necessary. In some areas, there'll be a little bit more. But you can see in this photo on the right side that we have good extensions on the labial. We have good extensions in the left photo. You can in the lingual side, and you can see that the lingual areas by the molars have been hollowed out a little bit to allow for the tongue to retain its normal position, which is very important for retention of the dentures. There's something else I'm going to mention here, and it may sound kind of weird, but the more highly polished a denture is, the more retention you will get from it. It isn't just about the fit of the dentures, it's also about the polish. Highly polished dentures, again, on the outer surface will be retained better than poorly polished dentures. So to review the material, the process for the successful reline, we want to mix it to the consistency of peanut butter. It's a little thicker than you might normally want to mix it. We don't want any runniness. We will fill the template. I say overfill the template, and I'm going to have to change that because we want to fill the template. We don't need to overfill the template. And you need to push hard in order to seat the denture. You'll push hard to seat that denture. You'll either to the stops that you have created. You have about 3.5 minutes of working time, so you can push the denture in, seat it to place, and then check the midline. Always check the midline first. Check with the Fox plate. Check the occlusal plane, Frankfurt horizontal, lip support, and you'll still be able to move it around if you need to. This is just some photos of this patient that I had just showed you with their dentures in place and prior to that. Here are some of the ways that you can customize it. The left photo shows a Y-shaped notch in the palate. There are two reasons why you would use a Y-shaped notch. One is if you have an extremely high palate. I suggest putting a notch in there and then folding up the palatal portions of the template. The reason being that if you have to push the template too much in the palate, and it won't break or it won't have a problem, but it will deform the occlusal plane. It'll torque the upper molars toward the mesial. So if you have to move it a lot, you can just create a notch, fold it up, put a piece of tape over it, and do the reline. The Y-shape isn't necessary if you just need to do the palate. If you need to move the anterior teeth, either flaring them or retruding them, you can put that notch across the anterior palate by the rugae area. If you try the template in and you see that because the patient had lost their teeth on one side much earlier, and you want to be certain that you can put the template to the right position, you can put a stop in with the reline material. This demonstration on the right side is just one stop so that the template is level with the occlusal plane. But you can place them tripodally. You can place one in the incisive area, one in the other tuberosity area. Try that template and to make sure you have it where you want it and go from there. The other customization, one of the other customizations that we can do, and this is an extreme. This patient had an extremely small lower jaw. And so we, with the smallest template, it was still in a class 3 occlusion. Everything else was right with the posterior teeth, but the anteriors were really far off from this tiny little jaw. So we actually took out the bicuspid on each side, took out the premolar, and created a notch across the back, put it in the boiling water, and just bent that anterior segment back. And then we're able to complete this actually with just 2 molars, and we actually moved it a little farther back than is demonstrated there. Many patients will allow, because they're not using the smallest templates to begin with, will allow you to use a smaller template for the lower than for the upper if you have a real class 3 situation. Because of the monoplane occlusion, they are all interchangeable. Here's some more customization that we are using. I'm going to go back to that, and I'm going to stop for a second here to make sure that I have my panel here. Okay, and now we'll go back to the slideshow. Okay, and no, I'll still go back here. So in this particular case, which we're going to show this case in full, but the other customizations that can be done is you can have the right size template. This in the upper left photo was done to the patient's natural lower dentition, and that's a question I get frequently. And the answer is yes, you can do this to the natural dentition in the opposite arch. There will be adjustment necessary for the occlusion. It will be necessary for either the natural teeth or the denture teeth to be adjusted. You have to, if you're dealing with natural occlusion, you have to deal with it as is. So in this case, the upper teeth were lateral to the lower occlusion, and the template fit properly, but there was an open bite. And we're going to actually go through this case in a few minutes, and I'm going to show you how we were able to easily correct this so that the right photograph is that same patient with the completed denture. The lower photo is shown for example. As an example, it is a template. It is a template that is tinted with the tinting ink, and we used 5 drops just as an example. You put the tinting ink in with the monomer when you mix the reline. Because the templates are translucent thermoplastic, the color will show through. So when you mix it up, it's going to look kind of dark purple. You probably don't want to make it this dark, and you don't have to. This was with 5 drops of ink. 2 drops or 3 drops is typical for the best result. This is a typical patient. You may have seen this in the poster. We use her as a demonstration. This woman was in her 30s, lost her teeth. Again, we don't judge on why people lose their teeth. There's many, many reasons. It's poor education, it's methamphetamines, it's Mountain Dew, it's diet, it's hygiene. It doesn't really matter. We're trying to create some quality of life here and give the patient function and give her the ability to smile and socialize and go out. And this was one of the patients that we did. They talk about cosmetic dentures, and I'm just going to briefly mention this. I don't believe there is anything that is a cosmetic denture. I believe there are only dentures that fit well and meet the principles, and these dentures meet the principles. They have filled out her lips. Her lip support is good. We have increased the vertical a little bit. This woman is also in her 30s, close to 40 years old, and she is looks significantly younger. And these dentures were done in about an hour in a single procedure. We're now going to go through a few case studies. And one of the more common ones is for immediates. This patient briefly came into the office. She needed an immediate denture, needed the upper teeth out. She was in pain with them. She could not afford to have a lower denture made at this time. So the treatment plan was made to take the upper teeth out, make an immediate denture for her, and then at a later date make a lower denture for her when she could return to the office. The canines were smoothed off a little bit on those distal edges, so that because we knew we would be coming back and making a lower denture at a later date. So the vertical was already established, and we measured our vertical with her teeth in place because we knew exactly where she would close to. The preparation of the template was the same, just demonstrated here. A model was taken, the template was tried onto the model. You can see that we're way up at the tip of the flanges, and so that was reduced so we would have our 2 to 3 millimeters of flange space prior to that. This was a shade B1 template, the lighter shade. So the teeth were removed, sutures were placed, the impression was taken. Now, I'm asked frequently what happens with the sutures and do you get material up into the sockets? Well, the answer is typically you can put a little bit of Vaseline or mineral oil over the sutures and they don't get picked up in the alginate. And the second thing is that because the impression is stopping at the palate and the ridges, there is nothing inherently in there to force the material up into the sockets. The model was poured up, and here you can demonstrate this, that it's demonstrated that the template was turned upside down onto the model to see that the teeth are over the ridge. So this way we know we have the right size model. We just try this way, try it the other way, see which one is the closest. If any of you were at the CDA meeting or the Hinman meeting or any of the other major meetings that we were demonstrating, you could see that the fit of the template when you try it on doesn't have to be real exact. It just has to be in the ballpark, and because it's able to be customized from there. So the template was done. The template was tried in the mouth. Make sure we have the right lip support. It was adapted on the model, so we knew it was proper. The sealer adhesive was placed that comes with the reline material. The material was mixed up, the reline and the denture was made for this woman. She was extremely happy with this, and she ultimately came back about 8 months later, and the lower teeth were removed and an immediate denture was made there. But you can see that the lip support is proper for her age. When she smiles, she's showing the appropriate amount of tooth. And the way that we check this is to try the template in before you reline it and have them say a few words like museum and church, 55 and 66. And what we're checking is we're checking to see that the incisal edge of the upper incisor is hitting the wet-dry line of the lower lip, because that means that the speech pattern will be good. So if we set that so this incisal edge is at the right spot hitting the lower lip, and we bring that template forward so we have the proper amount of lip support, and we also check with the Fox plate, we know that we're going to have a denture that is going to meet the principles of fit, form, and function. And of course, the patients are going to get it less expensively, and they're going to be happy, and they're going to also be happy because of the convenience of being able to get that in the single visit. We do a lot of immediate load implants for dentures. And in this case, we were remaking the lower denture. This is one of those lower dentures where you have the second molars and 2 premolars, and you can see how far back that dentition is. And this denture actually was unseating itself quite often. And it had fractured a couple of times, and it was just no longer functional. It had been trimmed back because those buccinators were moving those muscles, were moving that denture around, and it became uncomfortable. So the dentist would trim the denture back and hope that the implants themselves would retain it. So it's possible to do this 2 ways. If the patient does not have the implants, you can place the implants and do the reline right over the housings on the implants, or you can place the implants and retrofit them, and that's what we're going to demonstrate is the retrofit technique, because this patient already had the implants. But because of that problem with the buccinator muscle, this denture was not as stable as it should have been with those implants. The process is the same. We take an alginate impression with the implants in place, pour it up in quickset stone, try in the template. In the lower photo, we're trying in the template right over the implants because it's hollow on the inside and needs to be relined. We don't have an issue, and we can see that we're going to get a really good occlusion for this patient with that template. The reline material is mixed up. We're using the Flexacryl hard reline material. I'm sorry? Is everybody able to hear me?
Yes.
Is everybody able to hear? Okay. I'm going to mute it again. All right. Somebody said they couldn't hear. We're okay now. Okay. So the reline is done right over the implant heads. It's not a problem. You just take it out before it's completely set. And in the lower left photo, you can see that we relieve the area where the implants are. The housings are placed onto the implants, and then the housings are placed onto the implants, and then the housings are picked up with more reline material. Then the denture is finished off. This was the rough finish on the lower denture, and you can see the size of the flange we have on the bottom, much expanded from the prior one. So this denture was extremely stable through everything. Here's a demonstration of the pressure indicating paste that I basically insist you use. I can't make anybody do anything, of course, but by using the pressure indicating paste on the inner surface, a thin layer is spread, not a thick layer, just a very thin layer, and then tried in the mouth. You can see the areas. This has implants, but you can do it for conventional full dentures. So the pressure indicating paste is used, those areas are relieved, a little bit more is placed. You don't have to take out the pressure indicating paste, and you will be able to have a very comfortable fitting denture. Articulating paper is used to check the occlusion to make sure that we have it leveled and balanced, and then the patient is dismissed. By using the pressure indicating paste, by using the articulating paper and checking that carefully, and we suggest a minimum of 3 times with the pressure indicating paste, you will get the best result. This is the case that I showed you the couple of slides earlier. The patient was having all of the maxillary teeth removed. We went through the process of actually the model you're seeing with the template on is done after the teeth were out, and we'll show you that in a second. So these are a little bit out of order. But the frenums were cut out for, the teeth in the maxilla were all being removed, and though these are a little bit out of order, you can see there's a notch right in the center of the template. This was the template where the teeth were too wide, and we had to bring those in. This was also the template that had an open bite, and we're going to show how that was done too. So the surgery was completed. The area was sutured, impression taken, model poured, template tried in, flanges adapted, and the template adapted to the model. You can see in the lower left photo much more clearly that we only have some premolar occlusion, and the teeth in the maxilla posterior are too wide. So there's 2 aspects of customization that we're going to demonstrate on this case. The first is we're going to take a diamond disc, and you can see it in the lower right photo, and we are going to create about a 1 millimeter notch distal to the canines on each side, a little wider at the incisal edge than at the other edge. The upper left photo shows those notches in place. The upper right photo and lower left photo show the notches that we have just made in the template. All of this customization is done prior to the reline. Once the reline is done, there's no customization that that can be done anymore. So all of this customization is done prior to the reline. So in the lower right photo, you can see we did make a notch right down the center and bent the template in, and I think that's going to show in the next slide a little better. But you can see that we've gone all the way through so that there is a hole from the outer surface to the inner surface. That was done intentionally, and the reason that was done was so that when we do the reline, a little bit of material will exude through that hole, and we'll be able to repair the embrasure area where we had made the notch. It sounds real difficult, but it's very, very easy. So those notches were placed, the template was placed in boiling water, and the segment was just bent down. And you can see in the upper left photo, you've got the notches in place. In the upper right photo, the segment had been bent down, and looking at it in the mouth in the lower left, you can see that we are getting close to our occlusion. Now, we still have some adjustment to make on the occlusion, and we will be adjusting both the natural teeth and the denture teeth, and so we'll end up with a good occlusion. The material is then mixed, and the reline material is mixed and placed in the upper denture. There was a piece of tape over the notch. In the upper left photo, you can see how we had a little bit of that material exude through that hole that we placed, and this is used to repair the embrasure. Excuse me. So the upper right photo shows the reline as it comes out of the mouth in the rough finish stage. You would take and do a rough finish on that either on a lathe or on a electric handpiece. I suggest the lathe or the electric handpiece because of the high torque. There are situations where you may not have one or the other, and in those cases we recommend a Dremel moto tool, and I use those battery-powered Dremel moto tool, which are extremely high torque, and they are very serviceable and are able to be used with the right collet. They are the right size to take the dental drills. So we are Placing a post dam, you can see in the lower left it was painted in. It's approximately 1 millimeter to 1.5 millimeters high and 1 millimeter and a half wide. And the finished template is in the lower right photo. It was polished up, tried in the mouth. Upper right photo, you can see we still have a little bit of occlusion to adjust, but when we get our final articulating paper in occlusion adjusted, you can see that the patient is in full occlusion. Those posteriors have been brought in, and this patient was extremely happy. He didn't have so many teeth missing in the lower that we needed to do anything for that, and finances were a factor for him as well. You can see in where the frenum was, we had to cut out a significant amount of frenum in this, and you can actually, even after you reline it, you can cut out a little more, and it still will be sufficient for you. I'm going to go through 2 cases now for maxillary implants, or one maxillary, one mandibular implant. This patient needed to have those remaining teeth removed. She ultimately did have the teeth removed. She had a Hour denture made as a temporary the day that the implants were placed. So she was able to wear this denture through the entire healing process, and so while the implants were healing in place, she was wearing the Hour denture as a temporary. When it came time to uncover the implants, the attachments were placed into the implants. A new denture was taken. You could use the old one, but in this case a new one, and it was relined again right on top of the implant abutments, and you can see where that is. On the lower left photo, you can see the amount of overflow that came out. We try to keep it a little less than that to finish it off. And then in the lower right photo shows the rough finish that was done with a lathe prior to the attachment and final finish. So the impression, the reline was taken right on the implant abutments. Rough finish was done. You can see that the areas where the implant abutments were relieved sufficiently so that the template can be tried in the mouth for a good fit. The housings were placed onto the implants. The reline material was again added to where it was relieved, and the housings were picked up into the upper denture. We already had occlusion. So the proper fittings were placed into the denture. In this case, we had sufficient retention that we were able to remove the palate on this denture, and it was not an issue. This became a very comfortable denture for this patient. It was polished again. Upper denture, the housings you can see in the lower left, the final retentive attachments of the blue, which I believe are some of the weaker ones, because if we put in the stronger ones, we couldn't get the denture out. So we put in the blue attachments, and this patient was able to wear this as her complete denture without any issues. So this was the use of a Hour denture for dental implants. These implants were not placed as immediate load implants, but they could be, and the process would be the same. Just placing the implants, the patient would normally be edentulous. We're going to go through another case quickly here. This is a case where all of the teeth were being removed. The diagnosis was made. The patient was resigned to getting dentures because of the perio and decay issues that she was having with infection. Because we were able to do a set of Hour dentures on her at a fee of $1,200, she felt she was able to afford to have some dental implants placed. And so this made a superior restoration for her. Again, the same process. The implants were placed, denture was worn during the healing process. When the dentures were uncovered, or the implants were uncovered, same process, do the reline on the lower denture. You can see it in the lower right photo. This was also a shade B1, the lighter shade. And we were able to make her denture for her. One of the factors that comes up, and I wanted to show this, is that when, and this doesn't only apply to Hour dentures, this applies to any dentures, upper or lower, where you have implant housings. There will be inherent weaknesses and weak spots within the denture because of the space that's taken up by the housing where there isn't structural strength from the reline or acrylic material. And it was for that reason that we decided to put in a reinforcing wire in this case. And this was done after the template, prior to finishing, polishing, but after the rough trim was done, a notch was created in the lingual surface, and the wire was bent and placed into the denture, and then it was covered over with some quick cure acrylic. And then it was, the final finish and polish was done. And again, the relief was done. You can see in the upper right the reline material put back into the areas of relief. Housings were put on the denture and on the implants, and the denture was picked up. Final polishing was done. Check with articulating paper and with pressure indicating paste, very important for both. And this patient was able to be finished up, and she was extremely happy wearing her dentures that were implant retained. And this, the example of this is just another example of how, and we'll discuss marketing in a few minutes, of how the denture can be, because it's inexpensive compared to a traditional denture, the patient can have implants done, and it can all be done in convenient visit, which will be a tremendous marketing advantage for you, because patients love to talk about how quickly they got it, and they always love to talk about how they save money. And since we're creating a quality product here, it's a good practice builder for you. The next case, this is the last case I'm going to show here. The last case is going to be a all-on-4 temporary reconstruction for all-on-4 implants. I don't know if you're all familiar with all-on-4s, but it's a process whereby the teeth are removed, 4 major implants are placed, and then a fixed temporary prosthesis is placed, and then after the healing takes place, then a final fixed bridge is made for the patient. They're done by Clear Choice, they're done by Nobel Biocare, they're done by other companies, mostly done by surgeons. Some general practitioners do them. This was done by a general practitioner. But rather than have a lab technician in your office for half a day to make the provisional, which needs to be screw retained, the Laurel template can easily be converted, and it's done by creating holes in the template where the implants are, putting the analogs in, and then putting retention screws and filling that with reline material, and then trimming it off, removing the pallet. And so you have a screw-retained provisional here, and a lot of doctors are using that right now and enjoying it. Let's go over some of the economics about it right now. It's 1 hour of your time. The cost of the templates and reline material are about $355. That breaks down to $175 per template, and about $5 for the reline material. We suggest the fee to the patient of $1,200 for the set of upper and lower dentures. We by no means are demanding that or insisting on that. You can set your fees at whatever you feel. Some doctors, if they're doing a single denture, will charge $700 for it. Some will charge $1,000 for the both set of upper and lowers. Some will be $1,500 for upper and lowers. It all depends on your particular practice, but using the numbers of $1,200 for upper and lower and the costs involved with the 1 hour of time, it brings you profit of $845 an hour. Now, if you have 2 hours of empty chair time a week, and I think most practicing dentists do have at least 10% open chair time, and you can bring in, what you will do is you'll be bringing in patients that you might otherwise not have seen, and you would not have seen them because they're not coming in because of the either knowing for sure that they couldn't afford the dentures or the implication that they can't afford the dentures. So you can add these patients to your practice, and if by doing that, it will really add to your practice. If you do 2 cases a week at these numbers that we suggested, it will be adding $125,000 to your practice. That's a pretty significant amount. I will also say that we do have some doctors that only do these dentures, and they will see 7 or 8 patients a day, They will only work 2 days a week, and their incomes are up in about $700,000 with very low overhead because there's no laboratory charges or other materials. So the initial kit, which we are going to offer at the end of the webinar for tonight and for tomorrow, we're going to offer a 10% discount. So that's almost $200 off of the cost of the initial kit. So that brings it down to about $1,750 for the entire kit. The kit comes with 10 templates. It comes with a set of upper and lower of each of the 5 sizes. It comes in either shade, and you would choose the shade, whether it's the B1 shade or the B65 shade, which is the universal shade. It comes with a package of the Lang Flexacryl hard reline material and soft reline material. It comes with the Fox plate, the boiling pot, and the tinting ink. It also comes with a DVD of the process. Now, and instructions on how to place the dentures. The soft reline material is included with the kit for 2 reasons. One, there may be patients where you're going to do an immediate denture and you want to have a softer reline on top of the surgical sites. So the softer reline can be used. It handles the same. It is mixed the same. Its working properties are the same. It just doesn't get real hard. And it does need to be replaced after 18 months. Of course, if you're doing an immediate denture, it's likely that they will need, the patient will need a reline in about 6 months. And so the soft reline for an immediate denture can easily be done. The other indication for the soft reline is where you will, for whatever reason, have an undercut or an exostosis that you can't remove. And I'm sure you'll see patients that will do that. The denture will be relined with the hard reline material. You take it out to do the rough finish, and you'll see if there is an exostosis or an area where repeated removal and insertion of the denture will cause irritation. You can relieve that area, place in some of the soft reline material only in that area, and that will allow you to have the retention and stability of the hard reline material for most of the arch, and a small amount in the of soft reline where you can have comfort for the patient. So again, the cost of the kit is $1,924 plus the shipping. The income that you'll derive from 5 sets of templates is $6,000. Reorders are $175 per template, and what most dentists will typically do is use a set or an implant or a template and then just order that template so that they have the full array. I think it's important to have the full array of templates available to you so that whatever size you need, you will have available. Many dentists have both shades available because they're not sure which shade their patients are going to want to have. So here's how the numbers work out. I'm allowing an hour and a half for each procedure. So just look at that for a second. Excuse me, I gotta take a drink here. 4 cases a week will add $250,000 to your practice. That's 6 hours. That's basically one day of practice. And since many dentists are down that, it will really be a good income boost for the bottom line. But there's other benefits. You'll add patients that you would have not seen otherwise, as I mentioned already. But many of these denture patients bring in other family members and friends and will promote your practice as innovative because they're able to get their dentures in a single visit. I don't want to underplay the importance of dentures. I know that many of you, and I hear this comment all the time, oh, I don't like making dentures, they're so difficult, you marry the patient, they're always coming back. We've created this easily learned system so that these patients tend not to come back. We have a very low adjustment rate, and we have just a great way to offer this so that it makes the patients happy. They will refer patients to you. You'll be happy because you're being profitable about it, but it's also an easy technique. It's intuitive, and it's really not difficult to do. No face bows, no fancy articulators. Everything is done in the mouth, which is the best articulator possible. Let's talk about marketing. Now, there's two comments I have about marketing, and I'll say that one, for either internal or external marketing, if you would like some photos, some before and after photos to market this to your patients, please contact me by email, and I will respond by sending you a couple of patients that you can use these photos in either a newsletter or a brochure or in a poster in your reception area. Marketing is done two ways. We are developing patient brochures, but we do not have them quite yet. We will have them before too long, and we'll make an announcement, and we'll talk about that on the website that we have. That we're rebuilding our website also to a much more robust website where we'll have some videos, and you'll be able to order on the website, and everything will be the way you need it. But let's go back to marketing now. Internal marketing. What can you do in your office to help bring in other patients? You can market this through an office newsletter. You can do it through brochures in the reception area. You can put it on your message on hold, and you can get word of mouth from your existing patients. The word of mouth is a very powerful tool to bring patients in. But office newsletters, whether they're printed or email, and talking about it will be very helpful for you. External marketing. Local newspapers. Your local newspapers are always looking for news stories. And if you're doing something that's very innovative and not been done before, which it really probably hasn't in your area, you can talk to your local newspaper and get them to come out and do a set, and maybe have one of your patients that you've done and show the newspaper that this is exactly what you need, and that what you're doing is very, it's newsworthy. Facebook is good, office websites are good, and speaking to local groups are, I found, to be the best way for marketing it externally outside of the office. But these areas are the areas where marketing will be the best. And again, I will supply you with some before and after photos if you would like. So to summarize it, and we're just about done with the didactic portion, and then we're going to get right into the video. It's an innovative one-step method for creating the dentures. It's profitable for you. The patient saves money. It's an $8 billion denture market out there. Every year, $8 billion is spent on dentures. You will see more patients, you will increase your income, and you'll enjoy doing your dentistry. And that's really what it's all about. So I'm going to leave this on the air right now. This is my contact information, and as I said before, we're offering a 10% discount if you order the kit tonight or tomorrow. I will be in the office tomorrow, and if you send me an email, we will make sure that you get the kit, and make sure that you mention in the email the webinar discount, and we'd be happy to reduce that. So basically you're getting more than a free template, which you can use as your first trial. So I'm going to pause it right now, and we're going to go and get the video set up. Okay, we're back on the air, and we're going to start the video, which is going to show the entire procedure. I'm going to be narrating this procedure. I'm going to stop this for a second here, and I'm going to unmute everybody. Does anybody have any questions? Are there any questions right now? Okay. Well, we'll go ahead. And start with the video. Remember, you can type in a question in the lower right section where it says type message here, and I will see it, and I will be able to answer the question as we go ahead. So now we're going to watch the process that we have done. And the first step, of course, is the template selection. We have the 5 sizes of templates, from the very small, which is a size 5, to the largest, which is a size 1. And you will get, in the first step, of course, you'll be making a model. And as I said before, we're trying in the templates. Actually, these are actually her old dentures. We're trying them in to determine the vertical dimension. Now, we ask the patient to relax and leave the jaws in a very relaxed method, and we mark the vertical. If the patient has no teeth, vertical is a guess, but it is an educated guess, and it does work out. So we have the vertical determined. We're going to select the template. We have the models, and we're going to try. This patient doesn't have really big ridges, so we try the template right over upside down on the ridge and can see that the teeth are over the ridge, and we're pretty sure that this is going to be the right size template when we turn it over and try it on, and indeed it was. It's not an exact fit, but it's the closest that we're going to get, and because of the thermoplastic capabilities, we'll be okay with it. Same thing with the lower. Try it to see that those teeth, posterior teeth, are over the ridge. This is a universal 65 shade. You can see by looking at the model that the teeth are over the ridge, but we do have some adjustments that need to be done to the flanges to shorten them up so that this template will fit real well. So we are now going to try that template in the mouth and see how the extension of the flanges is, and get a basic idea of the allotragal line, get a basic idea of the tooth show when the patient is smiling and speaking. And we're going to ask her to say a few words, but we just want to make sure that we are in the right ballpark with the template. We're now going to configure the template, and we do that off the model. And you can see she's got quite a bit of resorption in the anterior maxilla. Put it on the model. First thing, mark that midline. Mark that midline of where the frenum is. Make sure that you are marking where you will be removing some posterior from the posterior border, from the tuberosities. In the lower denture, where the flanges are a little long, you will want to reduce it. At room temperature, these templates act as standard denture acrylic. You can use an acrylic burr. You can use a green wheel, as you can see on the lathe right there. You can use whatever grinding stones, and in this case, an electric handpiece with a acrylic burr. And you can see that it does trim, as long as you don't get the speed up too high and really wail into it. You won't burn the plastic, you won't melt the plastic. It will be just easy enough for you to trim away the areas that you want to trim, so that you have the right height, the right ability to mold this to the tuberosities and mold it to the model. And we do the flanges first before you mold it to the model, and the reason is that you want to be able to seat this completely on the model, and sometimes those flanges get in the way. So it's just a matter of taking and trimming off with the acrylic burr to the areas that you want. You want to take off a little of that labial there, because that's where that buccinator comes in. You want to try and leave the lingual as much as you can, and taking it away. So now that you see you've got that pretty well set on the model, it's time to use the boiling water. In the boiling pot, the water is 212 degrees. It is boiling. It's been in for about 40 seconds. And you're going to see in a second here that as soon as it comes out, it's malleable. And you'll be able to fit that to the model. We put it back in because it does cool relatively rapidly. The doctor's wearing gloves, but with gloves it is easily handleable, and it does cool very rapidly. So the first step, of course, is to make sure that the midline is set right, because if the midline is set right, set wrong, everything will be wrong. And then the next step is, of course, to use your thumbs to get the template set up in the palate, and then you can go start moving the tuberosities and the other flanges. As I said, there's no memory to the thermoplastic, so you can put it in the water as many times as you need. There's no limit to that. If you want to move any of the teeth around, do it when you put it in the water this way. You can rotate a tooth a little bit. You can tip them a little bit. Anything you want to do. The material, see that how malleable that is? The material is much thicker where the teeth are, so the flanges will become malleable before the area where the teeth are. So the teeth aren't naturally going to distort from being in the boiling water. But you place that down, and you'll see that he's going to form that right to the ridge, so we get a nice tight fit, and that will allow that to be relined properly. You make sure there's no interferences between the tuberosities and the retromolar pad areas, and that's usually done when you trim the model back to the retromolar pad area. We're now going to do the reline of the upper denture, and this is a very typical case. The adhesive comes with the kit. It's in with the reline material, and the denture is painted. We paint it right to the flanges, and we paint it right over the flanges so that the reline material and the roll that you get from the border molding will have a good attachment. If at some point you find that you need more, you can salt and pepper it to make the area smoother, just as you would do with any acrylic repair. We use about 4 droppers full. It's about 6.5 milliliters of liquid, of monomer, that's placed into the cup. And I do recommend those silicone mixing cups. They're a little bigger than the plastic cups that come with the kit that are rigid. So we're using the Flexacryl hard reline powder. It's mixed to a thick consistency, and you'll see that. He'll mix that to the thick consistency, and then it's placed in. Again, we don't want any runniness to it. We want to have it thick so that there's no running when it's placed in the mouth. It also makes for a more solid reline with less issues down the road as far as staining, of which there will be about a 2% staining after 3 years. But it's in an area that you don't see anyway. And there are sealers that you can get to seal the reline material. And you can see that by tipping that, it's really not running. You do get about 3.5 to 4 minutes of working time. So the material is very easily mixable. It's got a good mixability. He's placing it into the template. We adapted this template fairly closely to the ridge, so we don't need a real lot of material. We want that template filled, but we don't need it really overfilled. And as you'll see, he'll probably take a little, I think he takes a little monomer and just puts it on over the surface and takes it to the mouth. Well, he didn't show that, but he's now taking it to the mouth. He's tried it in the mouth ahead of time. He knows exactly where he wants this, and he seats it from the back forward and checks the midline first. The first thing is, of course, check that midline to make sure that that's on. Check that midline, and then check the posterior planes. He is not going to check it with the Fox plate right now because he's done 1,000 of these and knows exactly where he wants it. But you can see he's pushing pretty hard there to get that. He's got the midline. He's adjusting the midline to make sure it's there. He's going to be doing the border molding very shortly. But as I said, there's about 3.5 minutes of working time so that he's able to check everything, including her speech pattern, to see that this denture is exactly where he wants it. He's then going to do the border molding while this is curing. There's one of the features of this material, there's a very low exothermic reaction. Because there's a very low exothermic reaction, you can keep this even in the mouth until it becomes hard. He's having the patient suck on his finger now, and that's also to get the vibrating line and to help with the border molding. Some patients find it too warm, and by the time the patient finds it warm, the setting is complete so that there won't be any distortion of the material when he takes it out. It's at this point that he's going to put a little Vaseline in here and just push it up around the labial surface so that the finishing is easier and none of the material sticks to the tooth, and it gets it out of the way. So it's 3.5 minutes or so, and everything is done from the upper. You can see right here that he has done the reline. You can also see that there's a little tiny void there that he's going to fill in. But he's got a good roll on the reline material, and he's now going to try it in again to make sure that it's fitting right once the material has set up a little more. And he's actually put it in cold water. He's going to try it in. This is for demonstration purposes with the Fox plate, so you can see that the elytragal line is set properly and that the Frankfurt horizontal is set properly. Again, the lip support and the tooth show were done visually. He's now putting in the post-dam. He's mixed up a little bit of the material, just a little bit, and he's just painting it right on, keeping it out of the hamular notch area because that tends to unseat it. He's placing a little bit of material right there across the back. We want to wait until this material is completely set before putting it in the mouth because we do not want any displacement of this material. The post-dam is meant to be rigid, and it's meant to be kept rigid. So we don't want to put it in too soon, prematurely, and have it displaced. So there's the post-dam in place. It was put in hot water. It cures right away, and now he's going to put it. And you do have time to just make it exactly the way you want. So you basically have virtually no revision necessary. You can do it all with the spatula. So now he's done the rough finish. He's trying it back in the mouth, and we're going to see now that this is now solid. And watch what it takes to get this denture out. So that denture is really in place. By having that upper denture in place, we have set the occlusion for function, we've set the speech pattern, and we have set the smile lines for the aesthetics, all done with the upper. Now remember, we haven't checked our vertical yet. We're going to do that after we place the lower. We have vertical marked, but we're going to repeat the process now with the lower template, which you have tried in the mouth to make sure that you can bring it into occlusion. Again, keeping it right over the edge so that you can see exactly where you want to be with the reline material. About 6.5 milliliters of material, of monomer. If you were going to put tinting ink, you would put it into the monomer before you added the powder. And it would make the powder liquid mix very liquid, and it would make it very dark, but it would show through real easily through the translucent template. So the material is mixed so that you have a complete mixture. It mixes very smoothly. He's added a little more. It was a little bit runny, and just for for time efficiency, you just added a little more. So we're now getting the material to the way that we want it, and we're going to be relining the lower denture. So he's going to place that right now into the template, and then he'll be putting it in the mouth. Okay, so now he's placing the template into the mouth with the lower reline material. He's going to have her bite down into her occlusion and keep biting until he measures the vertical. She's biting into occlusion, so we've established occlusion. We know what our pre-template vertical is because we've got the marks on the nose and the chin. He is setting it right and doing a little bit of molding, border molding on that, but he's having her bite down, and you'll see he's going to measure the vertical dimension in just a second. The border molding, the occlusion, the vertical, all done with the lower template. The plane is established with the upper. And you can see we're just about right at the vertical. You can see that she doesn't have excess angular problems with her lip as she had before, and that the lip support was good. There's the lower reline done on the roll, with the roll, the excess material, which is going to be finished off. There's usually a little more on the inside. This is where we demonstrate the pressure indicating paste. The rough finish had been done, post-dam has been placed. We suggest 3 times for the pressure indicating paste. The thin layer is placed. There are typical areas where adjustment needs to be done. We're using a different brush there so we don't contaminate anything. The areas that will be mostly necessary to be adjusted will be in the tuberosity areas, the lingual areas in the lower, and in the incisive canal area, and the rugae. The rugae are movable tissues, so we typically will get some movement there. So there's what the template looks like. It's been relined. It's now coated with the pressure indicating paste, and he's going to place it in the mouth so that we can see where the high spots are. I just learned just recently that inside of on the lateral surface of the template in the tuberosity area, some doctors create a little space there and just relieve it a little bit to get better suction. We want to make sure that that template is stable, it's not rocking. We want to try and move it a little bit. And you can see that right there in the center of the palate, in the tuberosity areas, and even along the post-dam a little bit. Even along the post-dam, it needs a little bit of adjustment. And it's doing the adjustment and doing it 3 times, minimum of 3 times with the pressure indicating paste, that you get the best result. You can make your own pressure indicating paste. It's very expensive for those jars of pressure indicating paste, but you can make your own with a mixture of Crisco and zinc oxide powder. You can see how difficult that denture is now to remove. And the Crisco and zinc oxide powder mix is mixed in a 1-to-1 ratio and comes out just like pressure indicating paste, and it's much easier to clean up. And you can see the areas where he's going to, again, adjust the tuberosities, post-dam. He's now adjusted the upper at least 3 times. He has the upper in place, and now we're going to put in the lower and use the articulating paper. Everything we're doing is to try and increase the efficiency and the use of the process to quickly get your patients through and yet create a stable, functional product. And you can see in these areas that there's a couple areas right there on the crest of the ridge where he's going to, in the retromolar pad area, and the lingual flange right there. Those are the areas that the patients are going to come in with sore spots. And so by addressing those now, you're able to eliminate the patients coming in for adjustments. We have maybe a 10 to 15% adjustment rate, and of those adjustments that need to come in, most of them are a single adjustment. I'm going to try and put the volume up here so that you can hear her. And here's a little interview with the patient so you can hear the speech patterns.
So wonderful. They feel like they belong in my mouth, and they're so comfortable. And I'm tickled to death with them.
And how was the process?
The process was great. It didn't take very long, and I feel like I could go out and that's it right now. This process is amazing that you did, and I
Okay, so that is the end of the video portion. I'm going to pause it for a second here and go back to the contact information. Now, I'm going to open it up for any questions. Are there any questions right now?
Unmuted.
Any questions right now?
I do have one question here. Is the video available on YouTube? I will, on request, I will email everybody, anybody who has a copy of this webinar. It is a more complete video than the ones that are on YouTube. So there are some videos on YouTube. Once again, we're offering a 10% discount if the kit is ordered tonight or tomorrow. And contact me by email. I know I'll have a list of everybody who attended the webinar tonight. And are there any other questions? There's a question here. Dr. Azaz asked if the relining were done would be problem separately, and can they both be relined at the same time? The answer to that is that if you place the templates prior to relining, if you feel that you have a very good relationship between the templates, you can reline them at the same time. You'll want to do the upper first and check that occlusal plane and check that speech pattern, and then you can go right in and do the lower. So the answer to that is yes, you can reline both of them at the same time, and some doctors do reline them at the same time. I hope that answers your question. Are there any other questions? Well, if nobody has any other questions, we will end the webinar right now. And as I said, feel free to contact me if you would like to order the kits, if you would like to get some before and after photos, and we will be able to provide anything you need. Okay, there are other. Oh, here's other questions. There's a question that was asked here about how long they will last. These dentures are made to last a minimum of 5 years. 5 years is the standard of care for the American Dental Association that dentures should last, because after 5 years there's resorption and there is can be problems. We have dentures that are now in the mouth for over 5 years, and so we would expect that they would last over 5 years. The soft reline dentures will need to be relined after 18 months to 2 years, and there's some music in the background, so I'm going to mute everybody right now. There's another question. What comprises the homemade PIP? Well, as I said, the homemade PIP is Crisco, which still is sold. It comes in a can in the grocery store, and zinc oxide powder, which is mixed in about a 1-to-1 ratio. It can be done in a little ointment jar, and so that you'll have it for use at any time that you want it. It's would be about 1/10 of the cost of the commercial pressure indicating paste, and is easier to clean up. Okay, and we have muted everybody so everybody can hear the questions. So if there are any other questions, you please type them in the lower right corner there. I'll just unmute us again for a second here. If there's any other questions, if you'd like to ask how to order, you can order directly through me. You could call me. We can take the credit card information over the phone, and we will send out the kits directly. When we have our new website built, we will be able to order online, but for the time being, we're not. The next question is, how polishable is the cold cure acrylic especially when you put a Y-slit in there. The reline material is extremely easily and well polished, and it is easy to be polished through the same way with pumice and then a high shine. There's many different pumices on the market that are both natural pumices and synthetic pumices. The Acryluster, I believe, is one of the artificial pumices. You do need to be careful with the artificial pumices because they're very aggressive and they can actually take down some of the teeth. You don't need to go at it very hard, and you can have a really good finish on that with the pumice and the high shine. The next question I'm asked here is, what is the name of the reline material? The reline material is Flexacryl by Lang Dental. It is the reline material is available in the hard reline and the soft reline. We can supply it to you, or you can get it from your own dental supplier. We tend to sell it at a lower cost than the dental suppliers, but you can get it from Shine or Patterson. Every one of the major companies does carry it. Again, for marketing to your patients, we'd be happy to provide some photos of before and after. And I'm going to unmute everybody again, so that if there's any questions, we can still ask them here. Are there any other questions that I can answer right now? Carlos, did you have a question? There's another question here. Would you say that the dentures are more or less equal in regards to base fracture? Actually, Dr. Azad, I would say that they are less likely to fracture, and the reason is that with the thermoplastic layer and the reline layer being bilaminar now you have two lamina, we get an extreme amount of strength. We've only had one, as far as I know, one upper denture crack, and that was in the area where implant housings were, and the two housings were right next to each other, and they were they had removed much of the area from the acrylic supports, so it cracked in that. Delamination, you ask about delamination. We have had virtually no delamination. By roughing up the template surface, by using the sealer, and by having a roll of the reline material, we have not had a delamination process. Are there any other questions? Oh, what about delamination? No, I got that one. Okay, so no, they're not subject to fracture. We've dropped. Look, any denture, if it's dropped and hits the right way, a tooth can break out of it, and that has happened. Since they are Myerson-Kenson teeth, which virtually every laboratory has, and that they are able to be repaired because they are standard denture acrylic, the acrylic can be repaired in a standard fashion, either in the office or in the laboratory. The laboratory would have no issue with finding another tooth and putting it in there, or you putting it in there and using however you would repair a traditional denture. Are there any other questions? Okay, none are typed. If we have no other questions, I have unmuted everybody. I want to thank everybody for attending tonight. I will be available tomorrow morning to answer any other questions you might have. And as I said, it's a great practice builder and a great addition to your practices with an easily learned technique. And we'll be happy to go through the procedure with you, and I'm always available for customer service. So we are going to end the webinar right now. I want to thank everybody for attending. Again, feel free to ask me questions anytime, and I'm here to handle any of your needs. thank you very much. I appreciate all of your efforts, and especially on the East Coast being a little late. We are going to end the webinar for everybody at this point. Gerald, thank you. You're welcome. And feel free to call me if you have any questions regarding this. Thank you. I'm going to end the webinar right now.